medical therapy of shock. And I don't know if he already has or if he's planning on giving a talk about device therapy of shock, which honestly, as more and more shock data comes out, what he talks about matters a lot more than what I talk about in terms of what people are recommending in terms of which way to go. But we'll go through this and see what we can do. So a little bit I'm going to talk about just general shock and then get into the meds and kind of think about the meds within situations. But shock in general, from a cardiogenic shock standpoint, is defined as systemic tissue hypoperfusion due to inadequate cardiac output despite adequate circulatory volume, right? So if somebody's bleeding out, they don't have cardiogenic shock. This is really just a heart that can't keep up with what the body is demanding. And in the shock trial, which is kind of this big trial a few years back, they defined it as persistent hypotension, so blood pressure less than 90, or a MAP 30 points below the baseline, cardiac index less than 1.8 with support, or 2.2 without support. And that one, in my mind, is always a little bit soft. We did a routine right heart cath on one of our heart failure patients last week, and their index was 1.7, and we sent them home. And then adequate or elevated filling pressures. But as you start to add up all three of those together, hypotension plus low index plus high filling pressures, you get a better idea about a sick person. So I really don't like these slides a lot, but the next two I think help to kind of really bring more into what's going on. So you take a hit to the heart, whether this be a big MI, heart failure, something else. Again, you've got your definitions over here, lactic acidosis as well. We'll talk about power here in a bit, all resulting in a reduction in cardiac output. That then causes hypotension, which causes vasoconstriction. Vasoconstriction then makes it harder for the pump to work, gives you more reduction in cardiac output. On the other side, you're not perfusing your kidneys, your liver, et cetera, et cetera. You get systemic ischemia, which then revs up your immune system and gives you inflammation. That then goes to cause more of an insult and a hit to the heart. But you get hypoxia-induced vasoconstriction, microcirculatory dysfunction, this kind of Sears response. Bacteria can translocate across the gut, all to lead to more badness. You also can have volume overload in this related to renin-angiotensin, right? The kidneys think that they're not seeing enough blood, so they crank out renin and angiotensin to retain more fluid, puts more of a stress on the heart, all of which ends up down here at the end with death. This one looks at it a little bit differently, but really emphasizes the fact that it's not only the heart that gets involved here. You quickly have trouble with this systemic inflammatory response, and that then independently will cause more of reduction in cardiac output, more of reduction in good systemic perfusion, right? You can have 3 liters a minute going through the gut, but it may not be perfusing the gut. It may not be adequately perfusing the liver. It's just kind of shunting through there, leading all to this vasoconstriction that just makes it harder and harder for the pump to work. The tough part about this is how the heck do you figure out how to turn this around, right? Clearly, if they have a big MI, relieving ischemia can help to turn it around. Beyond that, it can be tough unless you do things like reduce LVEDP, improve cardiac output to kind of start to turn this around. And that really, from a cardiac med standpoint, is really all we have. Try to diurese and get rid of the pulmonary congestion. Try to improve cardiac output to slow down or hopefully stop all of these things that come up. Other things to think about with shock, right? Protracted hypotension, need for catecholamines to keep the blood pressure up. The end organs are not being perfused. You have cool extremities with this. You can have changes in mental status, the narrow pulse pressure. So that patient with the blood pressure 90/70, pulse pressure 20, that's ugly. Hemodynamic criteria, and then the elevated lactate, metabolic acidosis, kidneys not working, all kind of get thrown into this. Now, this has been out for a little bit of time now, but these kind of shock stages, right, that you see, where you have all these patients at risk that are considered to be stage A. And so they're going to be pretty much everybody that's had an acute MI or acute on chronic heart failure. And then you've got the Bs who are beginning to have cardiogenic shock. They're hypotensive, or they're starting to be tachycardic, but they're still perfusing everything. Stage C are the classic cardiogenic shock. They are not perfusing well enough. They need more support. These are the people that we normally are seeing, we're dealing with kind of from a shock standpoint. And then you get the ugliness here of the Ds and Es, which are really just crashing and burning, or they're there, they need ECMO, they need something like that to get them going. Now, in the past, we always used to thought about shock as being acute coronary syndrome. So if you look at all shock in the units, the vast majority of it is still 2/3 is cardiogenic here. Very little is hypovolemic. We're not seeing the people that are bleeding out. Saw a lot more of those in Baltimore, but fewer of those here. Distributive kind of septic shock, a little bit there. Mixed cardiogenic and septic pops up this way. If you look at that cardiogenic group here, only 1/3 of those are acute coronary syndromes. It's interesting, I think with COVID, that might be a little bit higher right now because we're having more kind of late presenting MIs. I think I've seen more late MIs over the past 8 months than I've seen in my entire life put together. And so this might be higher, but in general, it's 1/3 of patients that come in with a classic, I just corked off my LAD and I'm going down. A lot of patients can be ischemic but not having an acute insult. Non-ischemic here in another quarter, and then a variety of other things here that we'll talk about a little bit here at the end as well. But it's a big mix of stuff. It's not just AMIs that we're seeing. Other things to think about, right, are the mechanical complications. So the person who's had a PAP rupture from their AMI, a VSD, that kind of stuff, acute myocarditis, RV failure, whether it be related to pulmonary hypertension, an RV infarct, whatever. RV without LV failure, I think, is something to think about. And then progressive heart failure, just in our chronic patients that are slowly but consistently kind of sliding further down the pathway. Things that we see less about, but at least keep in the back of your mind: sepsis, anaphylactic shock, neurogenic shock, and hypovolemia. Again, much, much less what we're dealing with. That's going to be more in the MICU and the NICU than what we're seeing in the CCU in terms of our patients that to deal with. So a lot of people will get depressed when you start to think about outcomes. Here, where I've talked to a couple of you guys, like, oh, everybody is dying. And the reality is, everybody dies, right? So outcomes in kind of AMI shock is really about 50% of the time somebody is not making it out the door. For those patients, early revasc clearly is the best thing we can do to save lives. Again, that stops that kind of pathway of ischemia and all the badness that comes from that if you can reverse the ischemia. But in-hospital mortality is still pretty bad with this. And so you've got to accept the fact that, 50% or so of these patients are going to die despite everything that we're throwing at them today. The other thing to remember is it's just not the ticker that's involved in this. And so, clearly 90% are on a vent. Kidneys get pooched about 1/3 of the time. 20% of the time they need some form, either short or long-term, dialysis to keep going. 50% of the patients are going to have liver dysfunction. 30 to 70, depending on the study, have altered mental status. And so expect all of this to happen. Warn the family that this may happen, and that it's more than just the heart that gets involved here. And some of these things won't turn around, and a lot of times it's this stuff that ends up killing the patient, even if you can protect the heart. Well, I want to throw in a couple of definitions here for you guys, because I think that more of the algorithms of stuff are going down this pathway, and a lot of these came from the shock trial. So the shock trial was this trial put out of not Henry Ford, but the other big hospital in Detroit. Should we emergently revascularize occluded coronaries for cardiogenic shock? And in the past, they would just sit on these and say it's too late. And so it's really just how do you open up acute MIs? Enrolled about 1,200 patients, about half of which had hemodynamics of some sort, and then 400, so maybe a third that actually had a right heart cath. They looked at a lot of different things. In the end, they didn't do a great job with opening versus not knowing, but they found that cardiac power is the most predictive thing of in-hospital mortality. And surprise, surprise, the younger you are, the better you're going to do. So just a reminder for what cardiac power is, right? It's energy per unit time. And so it's essentially the rate at which the heart impacts hydraulic energy into the arterial system to maintain the circulation of the blood. So how much work, how much power is the heart able to deliver to get that blood going through? Now, I apologize here for whatever reason I don't have the calculation, but essentially it's your mean arterial pressure times your cardiac output divided by 451. So MAP times cardiac output divided by 451 gives you your cardiac power. And you get a feel here. Here's normal, where you have a cardiac power kind of hanging out in the 5 range. If you're really working hard. At rest, you maybe have a cardiac power of 3. As you have acute heart failure and cardiogenic shock, you're dropping to a cardiac power less than 1, right? So this is a MAP of 80 times a cardiac output of 3. That's 240 divided by 450 gives you a power of about 0.6. That's a patient who's really sick, who's not going to do well. And this from the shock trial shows that the lower your cardiac power is, the higher your mortality is. So if you get down to that power of 0.6 or so, again, half the patients are going to die. If you're down in this 0.2 range, 80% of your patients are going to die. So it's an easy calculation that can really make you get an idea about prognosis and how quickly you need to jump on these guys and not sit back and give them 8 or 10 hours of, oh, let's see what happens with a little bit of dobutamine. You need to quickly try to reverse this low cardiac power, low output state if we're going to be able to turn a patient around. This gives you an example, just splitting up patients with heart failure. If their cardiac power index now, so essentially divide by 2, so index greater than 0.44, so think about a power maybe of about 1 or less than 0.44, you see these huge differences in survival based on how patients are doing, just based on this cardiac power index. So start to think about that. We need to think about more than just the MAP, but cardiac power as a better, probably a way to prognosticate and treat our patients. The other thing about cardiac power, when you add SVR to it, is it really helps to sort out what's going on with shock, right? So if you think about SVR, systemic vascular resistance, if you have a low systemic vascular resistance, the patient's vasodilated, they can be very hypotensive, but the reason is because they're in septic shock. So low SVR start to go towards sepsis. Those patients tend to have a normal cardiac power. You've all heard me joke about the fact that sepsis is the best treatment for heart failure, right? You have a really good vasodilator, arch-like vasodilators, and so you see an improvement in cardiac output in the setting of sepsis. In contrast with cardiogenic shock, you see a high SVR and a low cardiac power, so this group here. If your patient's doing okay with heart failure, they've got better cardiac power, they may still have a high SVR. That's why we try to treat them with ACE inhibitors, vasodilators, that kind of stuff. If they're just in a hypertensive emergency, their cardiac power is good, right? Their MAP is high, they can generate enough cardiac power. They also, though, have a high SVR because the peripheral vasculature is trying to clamp down because the brain doesn't like to get all this pressure jacked up at it. So this helps to think about it. And for me, the first thing I'm doing when I see one of these patients is, what's their SVR? Is this sepsis or is it just cardiogenic? And then what's their cardiac power? how aggressively and how quickly do we need to amp up kind of the amount of support that we're giving these guys. Now that gives you an idea about the LV. On the other hand, I think you need to think about the RV as well. And so for the RV, think about PAPI. It's not perfect, but it's something to think about. So PAPI is the PA pulse pressure divided by the RA pressure. It gives you an idea about what the right ventricle is doing. And do you have RV failure or not? So PA systolic minus diastolic divided by the RA gives you the PAPI. A lot of studies have shown this is good. Some studies have shown this is bad. But I think it really is one of the best things we have. And so this is from the ESCAPE trial. The ESCAPE trial was Swan versus no Swan in patients with heart failure. And you can see that the lower your PAPI is, and think about a normal PAPI maybe being above 3, 3.5, the higher your percent of badness is in terms of mortality. And here you get down to that PAPI of about 2, and about 25-30% of those people didn't survive out of the hospital. High PAPI here versus low PAPI, time in days, it distinguishes fairly quickly. If you look at in a different study, the same type of thing in terms of death or rehospitalization, the higher your PAPI is, the better you're going to do. And this is, again, is a marker of RV function. Now, an easy PAPI, at least for me, because it's less math, is to just do the right atrial pressure divided by the wedge pressure. And in general, your RA should be about 1/3 or so of your wedge. But if you get to that where that RA and the wedge are about the same, so say RA of 20, wedge of 22, 23, and you're down there in this kind of 0.6, 0.8 range, again, you can see higher and higher mortalities as you go up from that standpoint. So walk in, think about the PAPI on a patient, think about the cardiac power of a patient, and then start to distinguish. Is this only left-sided heart failure? Is it left and right heart failure? Is it only right-sided heart failure? Because your therapies are going to change based on what you do from that standpoint. So clinically, what do we want to do for these patients? Number one, we want to support the circulatory thing. We want to increase the MAP. That's going to give us an improvement in urine output. It's going to decrease serum lactate. So clearly, you want to perfuse the organs. You want to get things going in that. You also want to support the LV. You want to try to reduce LV pressure and volume. You can try to do that with diuretics. If diuretics don't work, you've got to go to mechanical support. And that may be a balloon, that may be Impella, that may be an ECMO. But you need to support the LV and get rid of that high LV pressure and volume that's there. And the best way to track that is really with your wedge. Can you unload the heart? Can you get that wedge pressure down? And then lastly, you want to perfuse the coronaries. And with that, you're going to see resolution of ST changes, you're just increasing coronary flow. That's what the cath lab is supposed to do before we hear about the patient, right? They take them to the cath lab, they open up that artery, and then they're dealing with the rest of the cardiogenic shock. So earlier this year, in fact, just last month, which was perfect, as I had to put this paper together, this talk together, this paper came out. And so a nice one to think about if you guys want kind of a review. I will say that they talk almost nothing about medicines and a whole heck of a lot about mechanical support, but at least it's a good kind of starting point for jumping off. Now, you guys have heard me talk about this 50 million times, right? When you assess a patient at the bedside, are they perfusing? Yes or no? Are they congested? Yes or no, right? So they're either warm or cold, they're either dry or wet, and you can use clinical signs to help you. So are they wet? Are they orthopnic, JVD, ascites, peripheral edema, crackles? Are they cold, right? Do they have a narrow pulse pressure? Are they sleeping normally? Do they have Cheyne-Stokes respirations, cool extremities, et cetera, et cetera? Now, when you go to shock, can you get most of this? And the answer is no, right? They're tubed, they're sedated. You can figure out some of this. You can look at cool extremities. You know if the kidneys are working or not. You can see if they've got peripheral edema. But getting a history about orthopnea, change in sleep patterns, you're not going to have it And so I think the big thing that we need to do is float the bird, right? Put the Swan-Ganz catheter out there and use numbers to help guide things. We've got a meeting Thursday night talking about this because this is a cath lab thing, and we're going to really try to push that when these patients come out of the cath lab, we don't only know that their LVDP is 40, but we also have a right heart cath, because everything I talked about with PAPI, with power, involves getting a right heart cath. So we need to get that and use it early. There's a whole lot of data that will say this is not helpful. I think some data is coming out that says it's starting to be helpful, and at least is not detrimental, if nothing else. So once you have floated the bird, what else do you need to think about? You want to serially assess lactate until it clears. You want to know what the cardiac output is. Here now, if the Swan's in place, they're using continuous output based on the PA SAT. So we have that. Think about cardiac power. Think about your PAPI. Is this right-sided only, left and right, et cetera, et cetera, et cetera. Know what their EF is. Serial echoes, Lord only knows. We're probably going to get 2 or 3 over time. And then refractory shock that you want to jump on quick is that low cardiac power, less than 0.6, index less than 2.2, and lactate that's going up and up. So what do you do for these patients? And this is straight from this paper that I just talked about, right? Treatment objectives: wean vasopressors and inotropes. So I'm supposed to talk about vasopressors and inotropes, and the management of shock is now saying get rid of them. And we'll talk about that in a second. Quickly and early escalate for refractory shock to try to get some heart recovery. So they think about splitting patients up. Do they have BIV failure? Do they have LV failure? And do they have RV failure? So what are you going to expect to see with BIV failure? A low cardiac power and a low PAPI. If you've got LV failure, low cardiac power, but a normal PAPI over 1. RV failure, power is going to be low, PAPI is going to be further low, and you're going to have high elevated RA pressure. So RA over 15, wedge being left. This is a case where you're not able to send blood from the right side to the left. So your LV filling pressures are low, your RA and your right-sided filling pressures are high. In that case, get the shock team and then think about, and so they're going right to ECMO in a lot of these patients. But if they have biventricular failure, something that we don't do well here, I think, is supporting both the left and the right side with that. And again, we're going to push more on that on Thursday night. If they're not in refractory shock from this standpoint, because their power's up, their PAPI's up, get the vasopressors and the inotropes off as soon as you possibly can, but not before you possibly can. So here's the data I'm talking about with right heart cath use and kind of a contemporary thing. And again, came out this year, and they looked at patients with shock that either didn't have a Swan at all, had a Swan, but they couldn't get the wedge, they couldn't get something, or they had a Swan and they had all of the numbers that you want. And look at the mortality based on overall. Using a Swan is a little bit less. If you're in stage D or stage E shock, again, Swans appear to be helpful, where the more of that data that you use, the better the survival is. That being said, stage E shock, right, 75% versus 50%, still a lot of these guys are dying. So I think in contemporary hands, data is starting to come out that using right heart cath guided therapy, probably for the first day or two, is worth doing. So you get to that point, and before they've put the Impella in or the balloon pump in, from a med standpoint, what do you have? You have inotropes and you have vasopressors. And I'm just going to try to split things up here a little bit for you to think about. So our two inotropes are dobutamine and milrinone. They work slightly differently, right? Dobutamine is a beta agonist, gives a little bit of peripheral vasodilatation. Milrinone is a phosphodiesterase inhibitor and gives more peripheral vasodilatation. Also gives more pulmonary artery vasodilatation. For so right-sided heart failure, due to high pulmonary pressures, you might win a little bit with milrinone. Doses are right here for you. Ignore the indications. I'm not quite convinced that's there. Half-life of milrinone is longer. And so one of the big side effects of this is that you can occasionally drop blood pressure. And so if you really have somebody who's on the low side, you don't have as much of a blood pressure drop with dobutamine. And listen to what I said. You don't have as much of a blood pressure drop. You still may drop the blood pressure with these drugs and with both of them, but perhaps a little bit less that way. Both will cause arrhythmias. Dobutamine is going to jack up your heart rate more than milrinone is. So if you're starting with a heart rate of 120, dobutamine may not be your best drug. And then think about if they come in on 50 twice a day of carvedilol, that's going to be in their system for a long time. You may get less benefit from dobutamine than you might with milrinone, which kind of bypasses the beta receptor from that standpoint. The other thing I think to point out is that milrinone is renally cleared. And so if you have somebody with progressively worsening renal function and you've got them on low-dose milrinone, they really are on a higher dose, because with time, as the clearance decreases, it hangs out longer, you're going to get more of the effect of the drug. You may actually start to see more hypotension related to it. The big study that we have with inotropes is the Optime study. Optime looked at milrinone versus placebo in patients admitted with an acute exacerbation of heart failure. The big thing about this, and why it doesn't really apply, is that to get into the study, you had to check a box saying, my patient's not sick enough to require an inotrope. So if you want to put a patient on an inotrope, they wouldn't qualify for this study. That said, in this study, no benefit whatsoever with milrinone. A third of the patients were either dead or readmitted within 60 days. The number of days of hospitalization was no different, and the mortality was really no different between the two groups. So no benefit from that standpoint. What else is out there? Things that we think about less, but truly for cardiogenic shock can be helpful at times. If you have somebody with an SVR of 4,000 or something when they're just really clamped down, is think about nitroglycerin. Nitroglycerin gives you some peripheral and coronary vasodilatory effect, can hemodynamically be helpful, may improve myocardial ischemia, reduced MR, and potentially is safer than inotropes. The problem with nitro is it's going to drop your blood pressure, number one. Number two is you quickly start to develop nitrate tolerance to it. And so if you look at percent change from baseline quickly with nitroglycerin, you get a nice reduction in wedge pressure, but then over the next day, you lose about half of that reduction. And so you can throw it in there, but it's a short-term win that's going to go away quickly. And again, in somebody who truly is hypotensive with a low cardiac power, may not be the drug for you. If their pressure is okay and their SVR is through the roof, sometimes you get some nitroglycerin on board and their pressure actually will increase instead of decrease. So think about it. If it truly is high SVR, cardiac output, not that bad, shock. Similarly, you can give nipride. Nipride is not available here, and so we tend to use a peripherally acting calcium channel blocker instead. But with that hemodynamic benefit, again, lowering the blood pressure. Part of why it's not available here is cost. Part of it is because of the thiocyanate toxicity, and it's hard to determine the effective dose. You've got to keep the A-line in, et cetera, et cetera. You can get some coronary steal with nipride. But another thing that you can use if you're truly trying to vasodilate somebody and not do anything else. So Circulation a few years back had a nice review about the management of cardiogenic shock, and there's no reference because it's only online. But again, the other thing to think about here are your pressors. And so you've got dopamine, which does tend to have a little bit of a different effect depending on the dose. That does not mean that low-dose dopa is good for the renals. There's no such thing as renal dose dopa. That's from the past. Get that out of your head. It's not there. But dopamine will increase your blood pressure, slowly increase cardiac output. As you go to higher and higher doses of dopamine, it tends to be more in jacking up your SVR and less of a cardiac output thing. So lower doses probably better for cardiac output, higher if you really are trying to manage a low SVR kind of septic patient. Norepi, epi, phenylephrine, and vaso are the other ones. And they work slightly differently in terms of how much alpha effect they have, where norepi probably has the most alpha and epi has more of a beta effect. And so this paper says because of that, you get more SVR benefit with norepi, more cardiac output benefit with epi. Most of this data is from the 60s, but at least you can think a little bit about that as a way to differentiate the two of those. Vasopressin really stimulates vasopressin receptors, does again crank up your SVR, doesn't really affect the heart at all. So again, in somebody who truly is more septic, vaso can be a better drug for them. Additionally, phenylephrine is just going to work on the periphery to increase your SVR, doesn't really have much cardiac effect. So if you want to go after the heart, dopa, norepi, or epi, dobutamine, or milrinone are going to be your best drugs from that standpoint. If you have to work on blood pressure, vaso probably before phenylephrine is the way to go from that standpoint. And again, more going to be in other units than ours. Now, all of these in general, I think, are bad. And so if you think about clinical trials with inotropes, and there's not a lot of them, they're bad. All of these drugs are going to increase your myocardial oxygen demand, potentially can increase ischemic burden, can cause more arrhythmias. And that's why this most recent paper said use in low doses for the shortest possible duration. Now, that said, I'm supposed to talk about this. And so, again, this paper from 17 tried to separate things out into different kind of etiologies. And hopefully you can see this, and I apologize if you can't. But think about what's wrong with the patient and then go to what to manage them. And your default should always be norepi. There's probably more data with norepi that it's a safe bad drug compared to the others, unless you truly just have heart failure and then you want to go to milrinone or dobutamine. So for a classic wet and cold patient with cardiogenic shock, vasoactive management, norepi, right? This patient has a low index, a high SVR. You want to support the blood pressure to the extent that you can, and then add the inotrope. Again, think about your blood pressure, think about your renal function, think about whether they have or haven't been on a beta blocker to decide between milrinone and dobutamine. I like milrinone. You don't see us use milrinone as much as I would like, and part of that is renal function. But when you can, I think milrinone is going to be a better drug in this setting. Now, if they're cold and dry, almost never see this, but cold and dry, this is just really low cardiac output, but their wedge is okay. Again, they need some cardiac output, so you want to think about an inotrope. If they need blood pressure as well, think about norepi, potentially dopamine, which may be a little bit less toxic to the body than norepi, but potentially causes more arrhythmias. And then if they truly are dry, think about a small fluid bolus, right? This patient with a wedge of 15 may live better at a wedge of 20 or 22. But be gentle with that because sometimes it can be tough to get it out. Now, if they have a combination of sepsis and cardiogenic shock, norepi is the way to go. This patient's going to have a low SVR. This patient's more on that septic side of the curve where again, sepsis is good for heart failure than the other way. Norepi is the way that you want to go there. RV shock, classically we've all been taught, RVs need preload. So make sure they have enough in the tank. Fluid boluses, just to increase preload, that will help the stroke volume and get things from the right side to the left side. If you're beyond that, again, sometimes you need to support with norepi or dopa. I also think that inotropes are good for the RV and can help to push things forward to the other way. And so throwing something in there can be beneficial. So here you're going to think about fluid, norepi, inotrope, for somebody who just classically is RV shock. Now, if that RV shock is because of a PE or chronic pulmonary hypertension, you may also want to think about a pulmonary vasodilator, whether it be an inhaled vasodilator or you might want to go to milrinone more than dobutamine because you get some pulmonary vasodilatation with it. Going forward further, normotensive shock, again, this is levo-fed every day, all day. Aortic stenosis. Aortic stenosis gives you a high afterload, right? So if you have a high afterload, jacking up inotropy isn't going to make it any better. You're just squeezing harder, but you still have that same small hole that you're trying to push all the blood out of. And so all you're going to do is just to hurt the heart and make it more ischemic if you push an inotrope in that setting. If you increase the blood pressure, so a little bit of phenylephrine or vasopressin, you can actually change the filling dynamics there and may potentially help things. But the big thing for this with aortic stenosis is you've got to fix it, right? You've got to open them up, whether it be surgically, percutaneously. Aortic stenosis is a mechanical problem that you have to fix from that standpoint. Now contrast that with AI. AI, all this blood going out, comes right back in. Things to think about there is that if you increase the heart rate, you shorten the amount of time that the blood is regurgitating back into the LV. So potentially, not definite, but potentially, you're decreasing the LV EDP in that setting. And so onloading the heart a little bit. And so sometimes speeding up patients with AI can be helpful. You can speed them up with a pacer. You can speed them up with dopamine. Again, this is something that needs to be fixed, and temporary management really can be with that. Mitral stenosis, in this setting, you're not getting enough blood into the LV. You may develop right ventricular failure because everything's backing up. Clearly, you got to open up that valve, but until you can get to that point, slowing the heart rate down can be helpful because you give more filling time, more time for the blood to get across that small hole, and get to the LV and improve your preload there. So don't jack up their heart rate. Try to avoid anything that's going to speed them up. So stay away to the extent that you can from epi, dopa, levo, because you may have more trouble when you speed them up and you want them to go slow. MR, in contrast, we see this with almost all of our heart failure patients where as they dilate up, they're going to get some mitral regurg from that standpoint. Think about adding inotropes here. This is all about improving forward flow in whichever way you may do it. Again, this is something that can be helpful if you get a balloon in there or an impella in there to pull more forward and less backwards from that standpoint. Now, if you have a post-infarct VSD, you're going to have blood going back and forth. You need to fix it. You need to support. And so this is going to be inotropes and norepi from that standpoint. Couple of last ones to think about with hypertrophic cardiomyopathy. That's a dynamic obstruction, right? And so there you want to improve preload to stretch that heart out. So giving them fluid, trying to decrease the squeeze of the ventricle can be helpful there. So stretch the heart out. Don't give an inotrope that's going to make them contract more vigorously and increase that obstruction. Avoid vasodilators. Slow them down because that gives you more filling time as well. Is going to be the best thing that you can do. So keep them slow and keep them well loaded up. Bradycardia, we can fix that, right? Pace them, do what you need to do. And then lastly, with tamponade, fluid can be helpful in tamponade because you got pressure on the outside. So if you increase pressure on the inside, you're going to get benefit that way until somebody can come. So fluid and norepi just to make that heart squeeze harder until somebody comes to fix the problem. And those are really kind of, I think, a good way to sort through things. So right heart cath goes in. What am I kind of shooting for? From an LV filling pressure standpoint, whether it be kind of an acute MI or end-stage heart failure, I think I want the wedge around 20. Classic for us, we're living with a wedge of 7 to 12. We talk about trying to diurese people down to about 15. In this acute state, wedge being a little bit higher, I think is a good thing. What about pulmonary pressures? And here it's thinking about it, right? Use them to think about PAPI. Are they real up, or are they normal? Normal PAs usually happen with acute heart failure. If they're jacked up, could this be a PE? Is there secondary pulmonary hypertension? What's the CVP? How aggressively can I diurese somebody? Again, think about the PAPI, that RA versus wedge. Is the RV failing? Do I have to worry about RV failure as well as LV failure, or is this just LV failure? What's the output in terms of inotropes? And then what's the SVR? Is this cardiogenic versus septic shock? And hopefully that gives you an idea about kind of working through a patient and splitting them up. And again, I think we're going to work hard to do a better job of having patients come out with a swan in place. Because if you wait that 5 to 10 to 15 hours and you slowly realize they're in shock, it's that much harder to turn the boat around than if you can quickly get this from the get-go. That's all I have. Happy to answer any questions that you guys have about this.
Do you want to ask a question? Go ahead.
Hey, Dr. Russell, it's Aaron. Question about like the non-invasive monitoring, like flow track and such. I feel like we use that a lot, and then it's not always beneficial, it seems like at times, and just want to know your thoughts on kind of the accuracy and how much we should rely on that.
So the flow track is looking at kind of the pressure wave that is sent to the artery, so wherever it is, and based on that, then you get an idea about cardiac output. This is probably what the iWatch, whatever version 7 is going to have. So you'll have your heart rate, oxygen sat, and your estimate of cardiac output. For patients that are in AFib, I think it's not as good. For patients on a balloon, it's not as good. For patients with Impella, it's not as good. If you don't have any of those settings, you probably get 80% or so reliability. But one thing you can think about, not in that setting, is if you see changes. And so if somebody has a flow track output of 3.5, and you put them on an inotrope or a pressor, and it goes up to 4, you can probably reliably take that. You may not have a cardiac output of 4, but you know that you're sending somebody in the right direction. And conversely, 3.5 and you're going down to 3, you could be in trouble. A lot of times I will use, they've got a CVP line or something, and so I'll have them take just a CVP sat as a poor man's PA sat and calculate a FIC from that to give you a better measurement of cardiac output. The downside of that being, if somebody's on a vent, you have no idea what their true oxygen consumption is, and so that's an estimate as well. So none of these are perfect. Use them for trends, I think, more than absolute numbers. Other questions?
I just wanted to say thank you because that was awesome.
My pleasure.
This is Chris.
So I keep saying that I'm going to you guys talks again, and I need to just suck it up and do it. So that may be my New Year's resolution here. And it's so much harder to do it virtually like this, but I know I need to do it. I'll get on it.
Dr. Russell, this is Joan. Thank you very much for that informative talk. I wonder if it would be possible if you could send out those slides to folks because they were kind of small on the screen and
Yep.
difficult to see, and also to let folks know that I will be uploading this to our YouTube channel.
I will send it to everybody on the invite list. How's that? If I can figure out how to do that, but I should be able to.
You
You're
could,
laughing at me.
if you would like, you can just send it to me and I'll forward it to everyone to make it easy.
Done.
Okay.
Almost done. Give me a minute.